Chiropractic subluxation models. Everybody knows that there is a range of controversies surrounding the term chiropractic subluxation. Many medical professionals, chiropractors dedicated to evidence-based practice, some mixers, claim that chiropractic subluxations do not exist. But how are we going to deal with this situation? Well, before allow the spreading cancer of subluxation denials, let's ask ourselves, why and what do you manipulate in a joint? Do not buy it before the end of this class. To understand properly the concept of subluxation, it's very important to discuss the old concepts of subluxations according to the history of chiropractic. One very important definition is the Stephenson definitions. These definitions give support to the MOPI model of chiropractic created by BJ. Stephenson said, a subluxation is the condition of a vertebra that has lost its proper juxtaposition with the one above or the one below, or both, to extend less than a luxation, and which impines nerves and interferes with the transmissions of mental impulse. This is a very philosophical concept created by Stephenson that was considered a chiropractor philosopher. And the MOPI model of subluxations had four principles that was needed to find in a patient. The first was misalignment or malposition. The second, occlusion or narrowing. The third, pressure or impingement. And the fourth, interference to the nervous system. And this MOPI concept, MOPI model of subluxation match with the sentence of Palmer that give sense to specificity of the chiropractic treatment that say that chiropractic do not manipulate, chiropractic adjust. And the problem of this concept, the MOPI concept, it was that it treats subluxation, this phenomena, like something out of the place. In the very beginning of chiropractic profession, our fountainhead or all that chiro, that's how we call Didi Palmer, the discoverer of chiropractic, he was in that time not so well embased in clinical, scientific, and anatomy issues. And this situation, because he was not a physician, he was not an anatomist, he was a magnetic healer that became magnetic healer after being in a long time a teacher and another profession that he had in that past time. And then this gap, this space he gave for about to solve some questions, to fill some doubts about how does chiropractic works, makes an opportunity for some former students, the first students in chiropractic that was students from the proper Didi Palmer. One of them was Solon Langworthy. Solon Langworthy, together with more two students of Didi Palmer that was called Oakley Smith and Minora Paxson, start a new school of chiropractic. The first reason to start a new school because they have some difference with Didi Palmer. They thought the chiropractic should do together with other types of procedures. And Didi Palmer in that time thought that chiropractic was need to be pure with just adjustments. And these guys, Solon, Minora, and Oakley Smith, start a new school because they went aloof by Didi Palmer. And then after start this new school, they solved to write a book. And this was the first chiropractic book. called Modernized Chiropractic, published in 96. And these chiropractic were called mixers because, how I say it, he wanted to do chiropractic with other types of procedures. And then they built the name mixer chiropractors. That's why we call mixers nowadays all the chiropractors that do chiropractic with other stuff like physiotherapy, needling, and myofascial release, and something like that. And then Oakley Smith, including, created another branch of profession called naprapathy, and Minora Paxson was the first licensed woman in chiropractic in her area of work. Yeah, and then these three guys in this book had the opportunity to uh, give a lot of new stuff. And this period of 93 and 96 was called the lost years of chiropractic. Of course, it was not lost for Van, was lost for Palmer because the Palmer was involved in many problems, lawsuits, and debts, and this gave space for new theories and makes the American school of chiropractic grow up and have a lot of spot on it. And in this book, he wrote, Solon Worthy wrote about subluxation and about other types of concepts that are very interesting that we can speak later. But what is very important is what he wrote about subluxation. He wrote that the vertebra is not logged in a fixed and permanent abnormal position, like a displaced brick on the wall. He also wrote its field of motion may be too great in one direction and too small in another. And then this is very important because this thinking build a concept that is very up to date about subluxation and joints function that is it was written there about the hypomobility. And this is very important concept that of course was not accepted for the Palmer from the Palmer, was not accepted for that family because they go on just with the philosophical approach and vitalistic approach that is very important also, but it was not so good to explain for physicians and people that wanted more scientific explanation about chiropractic that was needy to stabilize better that profession. And some guys say that this book was also important to make difference in a course in a process of a guy called Shigetaro Morikobo, a Japanese chiropractor that was persecuted to do osteopathy. And this book said a lot of important things that differentiate, that say that chiropractics is not the role of artery, chiropractic is nervous systems, and all these concepts was inside this book. It's a very important book for chiropractic. And then it's very important because this concept say that this book said that the vertebrae is not logged in a fixed position, and this is very good for to understand that what is subluxation, and this was not accepted in that time, but is a concept that we can accept better and understand in the view of in other branches of the health science like physiotherapy and osteopathy and medicine also. The amazing part of this history is when Solon say about the vertebra is not logged in a fixed and permanent abnormal position, and talking about the field of motion that can be great in one direction and small in other. He was fighting about the concepts of Palmer that was proposing all the time and trying to improve all the time, even after this concept of Solon Langworthy, even after this book, because MOPI model was composed after the age of the modernized chiropractic. And when he did such a thing, and when he wrote this in this book, he was fighting against the model of Palmer that was static in the Palmer family. BJ went on trying to improve this concept that was already not up to date, even from that time, from the lost years of chiropractic, and that what we can say that really was a lost year of chiropractic for Palmer. And in the modernized chiropractic, when Solomon Worship say about this, he started like a pioneer, like a like a seed for dynamic model of subluxation, functional model of subluxation, but nobody accepted, nobody recognized that because he was not Palmerian. He was not from the Palmer College. And what happened after that is Henry Gillet, everybody know that he started with the functional model of subluxation, but nobody recognized it at that time what was written in the modernized chiropractic talking about the against the static model of subluxation. And then this got stronger with the Henry Gillet concept. And after the Motion Palpation Institute, when Dr. Leonard Fay start very, very influenced by Henry Gillet, a work about another new concepts, but is very, very more up. Finally, we have here the five components model of subluxation here. This model was originally proposed by Leonard Fay. The components are kinesiopathology that's related with hypermobility or restriction of movement, myopathology that is related with trigger, the presence of trigger points, taut bands, and some muscle spasms, and neuropathology not necessarily linked to the compression of nerves or roots, but due to the interferences of receptors, due to proprioception changes, and also uh, joint dysfunction. Histopathology is represented by the damage to the tissue, maybe to the cartilage, to the bone, and the soft tissues. And histopathology is related with the biomechanical stress and biochemistry. Biochemistry is what happens when you have damage of the tissue, and when the damage to the tissue happens, there is a release of arachidonic acid and the inflammatory cascade. And this is very important and very classic subluxation model. In this model, there's no type of hierarchy or supremacy of one component of over the others. Was proposed differently of the nine component lens model, that in this case the lens model was an improvement of the Fay model of subluxation. The lens model have nine components, and we shall consider that the other components proposed by lens was something like secondary to this five components. And in the case of lens model of subluxation, there is a hierarchy and supremacy from one component to the others. Like kinesiopathology in the lens is supremacy. Okay, is have a high level hierarchy that could affect the others. And then I like to study the five components, but incorporating the physiology and the sense of relation of the lens component, that's non-component of subluxations, that brings more relation and brings the kinesiopathology, the kinesiologic effect and the dysfunctional hypomobility to a high level, to the top of the pyramid, and brings special hierarchy and supremacy of these components to the other. And that's what how I study. I prefer to study and to teach because it's easier to understand when you put the kinesiopathology, that is the main character of the dysfunction, bringing effect to other components. And that we start this, we can adapt this in the phase movement and phase model of subluxation. And we can use the kinesiopathology like axis, a center, the top of pyramid that brings effects to other, like we can see. And when you have a kinesiopathology, you have stress and biomechanical stress due to the restriction of movement, and this brings, and the course of time brings histopathology. And also, the kinesiopathology may brings also change in the receptors, and this will bring difference of inputs, excess of exciting stimuli in the nervous systems, and brings also neuropathology, not exactly, not necessarily compression of nerves. And then this way we can observe better, the better way to look how each component can be affected by the kinesiopathology. Like here, kinesiopathology brings to the stress of hypermobility, histopathology, and then the damage of in the tissue brings biochemical change, like the formation of the damage in the membrane cell will have an inflammatory cascade that brings substance P, prostaglandin, histamine, and bradykinin, and others. And these components can affect the other components also. How can affect? Bringing change in the receptors and making effect in the ligaments like that. And the ligaments will bring more imbalance due to the laxity because of the edema, and also may bring in the nervous systems more sensitivity to the pain, and this will bring another effects in muscles, and this will bring imbalances, and this imbalance will affect the kinesiopathology. That's what we see in this illustration here. This is a complete solution schema that I adapt using the lens way to think, and the phase model with is more simple, with more didactic, is just five components or subluxation. And in this situation we can see well all the possible effects that we have in each component one to each other. We can see here how the biochemistry can affect the myopathology, neuropathology, and also kinesiopathology, releasing a substance that can bring in interference and different stimuli. And also, we can perceive thus in the illustration, we can observe that kinesiopathology, due to hypermobility, generates biomechanical stress capable of leading to histological and pathological change in the tissue, and the release of chemical substances, and due to the arachnoid acid, and finally through the inflammatory cascade substance P, and inflammatory catabolites act on nerve endings, cause irritation, and leading to increased central and peripheral sensitization, and this will bring formation of trigger points, referred pain, and also taut bands. And also, this will affect completely, bringing influence to the neural receptors, joint proprioceptive signaling, and other dysfunction manifestations. Neuropathology do not necessarily refers to the compression of nerves, how how could claim the MOPI Bartlett Joshua Palmer models that say that would be needed to have a compression in nerve to have a solution. Not like this, because if you have chemical issues here, if you have activation of receptors, you have change in the proprioceptive reactions, and also this will bring some excess of stimuli in the nervous systems, and this will bring unbalance for the joint and for all structures that works together to keep the balance to the joint. And then here we see this illustration that demonstrates kinesiopathology affects neurotransmitters, generates pain, and afferent joint impulse and adaptive reflex change, perpetuating joint dysfunction. And we say neurology or neuropathology does not necessarily refers to nerve compression as static models, but rather due to the excess of stimuli caused by proprioceptive kinesthetic alterations and due to this compensation of the other components. Now we have the table of five components subluxation model from Leonard Fay with some details. And the first component we changed the name for neuropathophysiology, that means in pathophysiological chains: irritation, facilitation, pathway via anterior, lateral, or posterior horn, and leads to hypertonic muscles, change in the sympathetic, vasomotor, and sensory systems, may take the path of pressure, degeneration, which leads to atrophy, sympathectonia, and anesthesia. And kinesiopathology reminds us Gillet hypermobility and Ely's hypermobility, Menos loss of joint play, and then joint play is very important, including the end fusion play that we can use it in evaluation. Then we can perceive that this, I like this five component model of axillosation because all these findings may help us to the evaluation process, and you can be very attention with a lot of attention to this finding to find something wrong in these patients, to have with others findings in the depending on the technique, if Constant, Thompson, or others, to do the more specific adjustment. And also, going on, myopathology could be in the form of atonia or spasm, which may be due to compensation, facilitation, or due to feedback chains in the nerves controlling the muscles of the joint. Muscle spasm may lead to an activation of visceral motor reflex. Histopathology, that is related with inflammatory process and also edema. Biochemical, related to stress response, including the release of substances like histamine, prostaglandins, and other canins. And this is very important, really very important, that we can use all these five components to do the evaluation of the patients and to see where and to seek better where the subluxation is, using the anamnesis, the visualization, the nervoscope, doing the right gliding path with nervoscope, and also static palpation and see there's pitting edema. There is some other findings like some changes in the anatomy of the body that you can help us to uh, see if something wrong with the patient. And also with motion palpation we can add some other stuff, like we say here, like endofusion play. We can use it, put it together to the patient. And we also must pay attention in when we evaluate the joint play and the motion of the joints, In other, like motion palpation and visualization in Adams test, in active or passive movements, seek for hypermobility. Yes, it's very important because hypermobility is maybe a failure of ligaments to restrain joint, um, amplitude of movement, the range on movement beyond natural limits, altered structural attitude at the extremes of motion. This also can lead to neurological and circulatory disturbance that we must pay attention, and also encroachment on the adjacent tissues. And this is very important because we have some concepts we talk in the next slide about hypermobility. And also, hypermobility is a fixation of a joint, is adhesion, is a chronic subluxation, pathological changes in the joint surface, and also structural aberration, because when there is a movement that is very, very strange and not typical, and it can be classic interarticular disrelation between joint and surfaces, like luxations, for example. Joint components abnormally at rest and forced into an airy attitude. Example, lateral flexion malposition. And this leads to inability to body for the body to adapt and compensate. It's very important. And I'd like to say some concepts that's very important, because when we talk with medical doctors, physiotherapists, and also osteopaths, sometimes there is a difference when how we treat these situations. And then we have the concept of hypermobility. We must perceive that what hypermobility is depends. There is the global hypermobility, and this is evaluation of Bayton scale, Bayton score, with reference indicated according to the sex and age group. And this doesn't mean that there is how can I say, a risk for instability. Doesn't mean, maybe associated with or related with this or no. But hypermobility in the global status may be a very good screening for some disease like Ehlers-Danlos, Stickler, Beset, and other pathologies that we can have attention to treat with manipulative therapy. And sometimes do not attend if there is a high level of hypermobility and not benign hypermobility. Some types of hypermobility that can bring easy way to extract vases, like have a dissection of the some artery, and this will be very harmful for our patient. Then we used to have attention with global hypermobility and do Bayton test on the patients. And there is other, the segmental hypermobility, when an increased movement of a joint or a specific segments occur within the normal movement of the joint. Okay, and then when we say about hypermobility in some joints, segmental hypermobility, these may be to dysfunction, yes, um, and the inflammation phase of some dysfunctions, but there is not instability. There is just increased movement, and this is not necessarily um, contraindicated to manipulation. But we have, Gonstead used to say, segmental hypermobility must be avoided to adjust, but it's not a problem to adjust. And then there's a lot of papers in the evidence-based practice that say you can adjust the hypermobility segment or the symptomatic segment, but you cannot adjust instability. There's a difference between hypermobility, that you have only excess of motion. You will just adjust using the right technique, right type of technique, and avoid to adjust, but only adjust if you have a lot of symptoms and if you adjusted the hypomobile joint and didn't work, and then you try hypermobility to adjust the hypermobility when it's symptomatic. And then you must be sure that you segmental hypermobility in relation to stress, to inflammatory process, and then sometimes the type of technique may be like something like low force or recoil technique that will not be harmful for the patient. And instability. Instability, we have the functional when there is not like a hypermobile segment. You have an aberrant movement. It's not normal movement that is increased movement. It's an aberrant movement that occurs through a translation in a joint to do it through the change in the muscle balance, for example. And then there is another type of instability. There is mechanical. This mechanical instability is when there is an aberrant movement, like not just increased movement, but aberrant movement that occur in a joint as a translation, for example, due to an anatomic change, such a fracture or a ligament change. This you cannot adjust because there is something like a luxation, so a fracture, or something that you can harm a lot the patients. When you have functional instability, the meaning of this finding is you must strength bring stabilization for the patient using muscle strength techniques to make more stabilization for the muscles and the joints in the area that you are treating. That is very important to talk to you. Yeah, and then I will just show you the 9 components solution models. I already told about this. This model was proposed by Lance, and it was from Life College West. And Lance adds to Phase proposed 5 component model plus this pathological connective tissue findings, vascular abnormalities, inflammatory response, pathophysiological findings. A common dominator between Phase and Lens model is the focus on the restricted motion of a manipulable solution. Such restriction or immobilization of the joint causes some degrees of degenerative change in the musculoskeletal systems and connective tissues that may affect the function of the nervous systems. The early introduction of movement via adjustment of or manipulation, mobilization, traction, or can overcome these harmful effects. So this is another view of solution, and I already showed to you. Is here, and you have more stuff than the 5 components model, and you have a hierarchy is like supremacy of kinesiopathology. Okay, the kinesiologic dysfunction is in the top of pyramid, is how I said before. Yeah, and then the kinesiology component is represented at the apex of lens vertebral subluxation model, emphasizing the importance of movements and the interrelationship with the other components. Movement is affected by muscle, guided, bounded, and stabilized by connective tissue, and largely controlled by the nervous systems. The vascular systems is the essential nutrition and cleanliness for all tissues and is the conduit for the inflammatory response. These are the tissue level components of the subluxation model, and each works in coordination with the others to allow the appropriate movement. Interference in just one component affect all the others. The neurological component, as described by Lance, includes nerve roots, dorsal ganglia roots, spinal cord, recurrent meningeal nerve, and joint neurology includes also mechanoreceptors and nociceptors in addition to related spinal reflex pathway. The connective tissue components describe the impact of joint mobilization and connective tissue chains. It includes bones, intervertebral disc, articular cartilage, interspinal ligaments, and related tissue elements. With immobilization, the synovial fluid undergoes consolidation and becomes more adherent and fibrous. The articular cartilage then decreases due to the loss of proteoglycans. The reduction gradually softens the cartilage until it is susceptible to damage from minor trauma. The vascular component and arterial segment passes through the intervertebral canal into the spinal canal, nourished each vertebral segment of movement. Through branching, this artery provides blood support for the ventral and dorsal nerve roots. It's like vasing nervo, like has nervo vasorum. We have vasing nervo also. Each canal contains veins that drains the spinal channel, and the spine also. These blood channels are susceptible to the same mechanical damage as nerve roots and can be compressed. Land suggests that immobilization can lead to localized venous stasis, creating a negative pressure in the area of immobilization, and lack of venous drainage can lead to inflammation. The inflammatory process can affect adjacent tissues and affects nerve functions as implied in the concept of chemical radiculitis. Inflamed nerves are hyperexcitable and show behavior different from the normal function. The dorsal root ganglia of normal nerves respond to stimuli and stop responding as soon as the stimulus ceases. In case of inflammation in the dorsal root ganglia, the response will continue and cease only some time after the stimulus ceases. When we get the knowledge of subluxation complex theories and models, we can understand the role of kinesiopathology and the relation of the stress and bringing interference in neurophysiology and the muscle balance and also the connective tissue organization. And all these changes can be related to the other models that we can find in musculoskeletal science, like the degenerative cascade proposed by Kirkle de Willis, that this physician, medical doctor, proposed a pattern of dysfunction that could affect the tissues and being related with osteoarthritis and in the aging process of musculoskeletal health, and um, present like a primary or secondary dysfunction of a cartilage problem, and maybe call it primary osteoarthritis or secondary osteoarthritis, and how this tissue change, histological change, can affect the anatomy of the joint and the mobility of the joint. And he designed a pattern of dysfunction that can affect also the facet joints and disc surface and histology, and may be divided in four phases. One phase is considered normal, like this, when you have a healthy facet and a healthy disc, and the second is the dysfunction phase. And all these systems can be very well correlated with the subluxation models, because in the phase of dysfunction, we have the obviously diminish of lessening of motion, hypermobility, and this will bring in the dysfunction phase damage to the tissue in the facet or in the disc. And this damage in the tissue will bring inflammation, that is biochemistry, and this inflammation will bring the release of certain substances that will bring edema and instability, and this instability may affect the facet joint and also the disc and the ligaments. And after this phase, that we have a lot of more mobility in this small phase, you will also have more disturbance in the nervous system, because more activity on the sensory termination, sensory nerves, and this will excite the nervous systems. And this excitement will bring a reaction to stop this excitement and will bring the stability. And after a stability phase, you will have certain cure of this status of dysfunction. And these stabilizations will bring adaptive change that can be considered reactions to diminish the excess of motions, the excess of information, like promoting new tissues that can stabilize these movements, like osteophytes and like spurs and bone that will be gradually occur in this joint, like changing the discs, changing the faces, and this process will be considered um, cured. Yeah? And then we'll find again another normal phase, but with lessened joint play, because it will be a cycle. And all the times we have normal phase, with of course all the time it happens again. You have a new normal phase because each time you have more tissue proliferation, osteophytes, and also uh, spurs, bone spurs, and diminishing space. And this will be all the times, all the cycles, diminishing the joint play of the spine or other type of joint. And these will each time giving phases like a dysfunction because of the stress that will happen in the face and in the disc, and after dysfunction, a phase of instability and then stabilization to stop that phase of instability to give a lot of information for the nervous systems. And this degenerative cascade is here detailed according with the teaching of Kirkal de Willis. And there is two paradigms, that is one in facet joints and the other is in the intervertebral disc. And in the very beginning, we will find hypomobility due to the dysfunction we have here, hypomobility phase. And after we have this hypomobility, of course, will happen in synovitis. Hypomobility is the phase of dysfunctions. And in the facet, we'll have synovitis hypomobility. And the intervertebral disc, we have circumferential tears. And after continuing the degeneration, we'll have in the facets, we have radial tears in the intervertebral disc that will go to herniation. And after, we'll find in the facet joint capsular laxity with internal disruption of the disc, diminishing the height of the disc, and bringing with capsular laxity instability. And then start the subluxation phases and the disc reabsorption that bring in lateral nerve entrapment. And then this getting to spoil this articulation, this joint, and the spoilment of this joint will bring to one level stenosis and getting worse with enlargement of articular process and osteophytes. You have a multi-level spondylosis and stenosis. And the role of chiropractic in the adjusting is to prevent the situation, this degenerative cascade. And we can understand well and correlate with the model of subluxation these three phases, that is dysfunctions, when fistula appears in the annulus fibrosus, cartilage of the face joints, and increases synovial fluid. This is the phase of discogenic pain, low back pain. The phase 2, histological instability, loss of disc height, and consequently ligament loosening and beginning of osteophyte formation, the Parrot's beak, which is an attempt by the organism itself to restabilize the motor follow-up. Discogenic pain accentuates. In phase 3, stability, spontaneous restabilization of motor tracking, fibrous disc transformation, and osteophyte formation. At this stage, discogenic pain improves, but unfortunately, osteophytes can compress nerve structures and cause neurological symptoms as radicular pain or also myelopathia. This is very, very concernable. And then when we see this image here, we have a vertebra that you may think, oh, this is normal. No, no, it is not normal. This disc is very swollen, and then in the very beginning of the dysfunction, the space in the vertebra is higher than normal because of the swollen disc. And after we have a diminish of the disc space, diminish of the head space, and uh, um, the diminish of the lessening of the motion in this vertebra, and this is phase that we call, yeah, progressive and related with the degenerative cascade that will bring damage on the facet and on the discs, and this dysfunction will occur in a cycle like I showed you before many times, and will be of course related with this complex of subluxation that we have here, and all the stuff here you can imagine that will be in the same pattern of this theory that will be in another view to understand what happened, and we'll get the worsening of the joint health and musculoskeletal systems health and relation with the aging process. And these Kirkland de Willis will be very useful to understand how can we um, give attention to our patients and what type of technique can we do more easily and to help without some collateral side effects, we say, without side effects and more easy for the patient. For Gonstead method, we have some rules to follow to make a proper diagnosis of subluxations and special features that we can understand. We first of all must understand the difference between misalignments and subluxations. You find many misalignments, but the subluxations are palsy. I mean, palsy is little, and then intervention should be only in areas of affected by the true subluxations, and then we can understand that the subluxations are um, like the primary cause of the dysfunction in the patient, and the misalignments are like compensations that are caused by the true subluxations. And then Gonstead developed a method that use five criteria, and these five criteria help to find the subluxation in a primary feature, and you must adjust the subluxation that is true to have the correction of the body of the patient, the spine of the patient, and this should be due to um, very, very specific analysis to have also a very specific treatment. Extreme care in the optimal positioning of the therapist and the patient. Gonstead also proposed that we have five mechanisms of defense that can keep the musculoskeletal system or the organism in a health status. And this mechanism was composed by the first is the base of the pyramid, that is alignment, that brings a better dysfunction to joints and set joints free from subluxation and misalignments. And after that, we have to consider the muscle support and release the muscle tension, tendinitis, muscle spasm. And after, the next mechanism of defense is the integrity of the ligaments, and after the disc cartilage, and after the bone is the last stage for the organism. And then we have here a sample of what is a subluxation and what is a compensation. And here you see that This was a vertebra. This was a spine with three subluxations and many compensations that we can call misalignments. And this, what happened when you adjust L3, you have to adjust only L3, and you got the correction of the misalignment that was influenced by this subluxation. And also, the same happened when you adjust the T5 and after T9, um, making the alignment in our spine and the healthiness of our spine just with three adjustments, because the other dysfunctions was just compensations that was caused by the primary subluxations. Ghosted will consider the term fixation and hypermobility, and fixation is equal to hypermobility. Instability is a pattern of aberrant movement, abnormal movement, and hypermobility means not abnormal movement, but increased or excess of motion, but not aberrant motion, or not wrong motion, but only increased motion. There is a huge difference between hypermobility and instability. And instability is not a manipulatable subluxation, and hypermobility is not recommended to adjust, but is not prohibited to adjust. And you will only adjust an hypermobile vertebra if you don't have an outcome adjusting the fixation, and there is still symptoms in the patient. And that's what Gonstead consider, and he say in these letters and writtens. And then the special tenets of Gonstead biomechanics is the ball pivot instead to facet restrictions. And then we must focus on it, the ball pivot disc biomechanics, and understanding that subluxations is caused by the dysfunction of the disc and not in the facet. And then it's very important to consider that the type of adjustment will be up and in. And this will be because you must respect the line of the disc, the disc plane line, and also to put the vertebra on the disc, like a special movement that we do in the technique. And then uh, we focus the correction in the disc and in some vertebrae, and in some joints that we don't have a disc, we focus the cartilage and also the something like a meniscus or surfaces of the joint in the same movement that we do when we have a disc, and we will do the same type of movement because it would be more effective and more long-standing effect. The vertebra is misalignments, posterior and inferior. To sit properly on the disc, the body must move superiorly and anteriorly. Gosted also considered that hypermobility is something that will occur when there is another segment with hypomobility. Of I can explain that. When in the presence of a fixation, the mobility suppressed in one segment must be assumed by another. The vertebra that has a greater mobility because it's compensating for the loss of movement of another is considered hypermobile vertebra. Do not confuse hypermobility with instability. And these patterns of subluxations are related and must be classified with subluxations listings. These listings are some type of code that we can discover the pattern of restrictions of this vertebra in a universal way. And then These listings are composed considering as a reference the spinous process. And then the spinous process would be on the right, yes, and this will be a restriction to go to the left in certain biomechanical movements. And this will go to the listing PR. And when the restriction is to go to the right, we call PL. It's not like we must remember about Solon Langworthy, and of course we say PL, but we are not talking about a bone that is out of place. We are talking about a bone, a vertebra that has lessening of motion, a vertebra that has diminished range of motion. And then when we say PLS, we are saying that there is a restriction to go to the right. The spinal process go to the right, like this. I'll show you here. The spinal process here are difficult to go in this way. And also this point go to this way. This is the difficulty for this vertebra to rotate, and the body goes to that side. And then when we say a PL, we say that the body is fixed on the right. The body is fixed on the right. And then we must consider the reference of spinal process when we are talking about Gonstead. We should never consider the body fixation. We must consider the spinal process fixations, and when we are talking about C2 until L5, for example. When we talk about atlas, it will be different. It will be another pattern of listings, and we talk about this after. And we have here, yes, we can have a PRS like this, and the spinal process is fixed in this position, and there is a difficult to go in this way because there is a fixation, and this fixation is, according with Constant, is due to the damage in the disc, and that's why we call biomechanical of ball pivot dysfunction. And then when we have PLS, that we have a restriction caused by dysfunction of the disc here, and this makes the difficult to spinal process go to the right, and then this is PL because have a difficulty to go to the right, and also make the right side up or make the left side down, and this is we call PLS. And to remember, we can understand that when the wedging here, this is a wedging, when the wedging here is in the same side of the spinal process, okay, same side is P R S, and here because the spinal process is on the right, okay, and when the spinal process is on the left and the wedging is on the left, we have a P L S. It's a P L S because the spinal process is fixed on the left, and they have a difficulty to go to the right. Is fixed on the left, and in the same side there is an open wedge, and this is called PLS. And here we have something different. We have a PLI pattern. Dash M we explain after. It's not so important here. Now PLI is because the spinal process is in the left side, or we can say there is a restriction to go to the right, and then he is fixed on the left. And the wedge is in the opposite side of fixation. And then this is P, L, I pattern. And the letter M is the contact that when you use to correct. And this is PRI because the spinal process is fixed on the right and the wedging is on the opposite side of the fixation of the spinal process. That's very important about the listings. And here we have a posterior left inferior. Here we have a posterior right superior, you see, because here you have an open wedge in the same side of the spinal process, and here we have an open wedge in the opposite side of the spinal process, and that's why we call this PLI and this PRS. That's enough to understand. Here we have another. Here we have a PRS, and we call this typical because you see that there is a change in the nucleo of the disc, and we can understand that in each case there is a difference in the pattern of the subluxation, because when we have the disc like this, we have several rings here, and that is a damage in some rings and makes the nucleus goes to more in one direction. The nucleus go more in one direction, and then makes the subluxations be like PLI, because the nucleopulposus goes to one side only more easily and makes the vertebra bending to one direction and getting restriction to the other direction. And that's easy to understand how to list the subluxations and Gonstead method. And that you see here, the vertebra is the nucleus of the disc is more posterior and on the right. When it's posterior on the right, we have here a PRS. This is due to the behavior of the uh, nucleopulposus. The nucleopulposus had this behavior because of the tendons of the damage in the disc. That is exactly in one side that makes some inflammations here, and these make more soft tissues, more liquid and more easy to go to the nucleus, go to the one side and not for the other side. Okay, and then the disc stage of dysfunctions, according with Gonstead, is a way to classify and to make a degree of dysfunction. Yes, and then we call D1 when there is a disc swelling. There is more space than normal in between one vertebra and the other, and the two discs toned posteriorly. This precedes the stage of sharpening. The three very toned disc is a chronic state. It's the beginning of chronic state. The four is disc is totally thin. The five, the disc is totally too thin. There is a severe damage to the vertebral body. D6 is extremely thin disc, is reduction above 2/3 or total vertebra. And then we can understand that these changes, of course, will happen in the facet joint, of course, and also we can correlate these changes with the Kirkcaldy Willis model. Again, we say about Kirkcaldy Willis model of degenerative cascade, that we have damage both in facet joint and intervertebral disc, but according with the Gonstead methodology, the intervertebral disc is very much more important to treat, to have a more effect, more long-standing effect, and more specificity. And then it's very important to understand the term of fixations, the displacement of the displacement of the disc peripherally, and balance the pivot effect of the nucleus pulposus, also decreasing the unilateral thickness of the disc. And don't forget the spherical pivot biomechanics, the ball pivot. And this what we can classify this dysfunction that is of course this score, Gonz's score from D1 to D6 have a lot of correlation with the dysfunction that the model of dysfunction of critical willism because it's related with an atomic change, and this anatomic change is of course related with stress, biomechanical stress, and damage to the tissue and the structure. And then we can imagine that this is that's, let me see here, this is a D1 and this is a D6, and maybe this is classified as a D4, maybe, I don't know, because I have just one view here. And this is related, exactly related. We can compare all these models and see what happened on it is what have in common, okay? And this also can explain the dysfunction that we say before, the phase models, or maybe the Lance model of 9 components. And then we have here a sample of X-ray plain film of D2, yes, and the D2 in English, we have aqui 4 languages. Disc tunneled posteriorly precedes stage of sharpening. Disco accordato posteriormente precede la fase di nitidezza. Scheibe nach hinten gestimmt geht der Phase des Schärfen voraus. And then we have here the 2 disc tunneled posteriorly precedes the stage of sharpening. And here we have the D4. Disc is totally thin. And here we have the D5. And the D5, the disc is too thin, totally too thin. Severe damage to the vertebrate body occurs. And D6, the disc is extremely thin, reduction about 2/3 of total vertebra. And that is very important to understand that subluxation concept start before the chiropractic history, and the concept emerged 200 years before chiropractic care. And due to the work of historians, these guys that are researchers that look for the informations in the writings, all the writings, and in the history, and do a lot of research to get this to come out, for this information for us to understand better in the timeline of history. These bring a lot of information to us to understand how some informations came and sometimes in the timeline disappear. And in 1746, Johannes Ericus Hieronymus say that subluxation of a joint is recognized by lessened motion of the joints by slight change in position of the articulating bones and pain. And there is a concept by Edward Harrison, MD, in the 1820, was already using the term of subluxation as cause of a joint and muscle injuries. Palmer's concepts were already known before his birth. Yes, that's proof. In 1821, Edward Harrison also said that when any vertebra becomes dislocated or too prominent, the patient experiences inconvenience from local or part of the nerves. He is, in consequence, tormented with a train of nervous symptoms which are obscure in their origin and stubborn in their nature. And then we go to our timeline that we have since 1894 from the Palmer School of Chiropractic Journal of the Chiropractor stated that 99% of the range were caused by vertebral derangements of the one of the 51 joints. And 93, 1930, the Palmer central hypothesis were described as a partial or incomplete separation in which the joint remains in the partial context. But we remember the more P also, yeah, we shall remember. And also, according with modernized chiropractic, we have the theories and the writings about Solon Langworthy, Minora Paxson, so, Oakley Smith, and then we also have the reinforced Stephenson, the concept based on BJ um, terms of model of chiropractic solutions, and also the dynamic concept seeded by Solon Langworthy. Remember that in modernized chiropractic he say about a brick on the wall, and then but it was not recognized because he was extra Palmer professional, and then Gillet have more strength to really start a new concept of a new model of solutions that is dynamic concept. Then after he came his pupil that was Leonard Fay, and then it's a very interesting um, timeline history, and we must know today that chiropractic solution complex is a vertebral solution is a set of functional structural pathological chains that are associated with interference in the nervous systems and its ability to regulate the body or promote well-being to the individual. And this is very important because if you cannot accept that there is a subluxation, and then why and what do you manipulate in the joint? What you manipulate if there is no subluxations? Because for us nowadays, subluxation. If you remember the concept of Solon Langworthy, subluxation is not a bone out of place. It's not a brick out of the wall. It's a complex of several changes and manifestations that are related with dysfunction in muscle and dysfunction in nervous systems and sometimes inflammatory process, and also, and then we have more than a putting out of a joint, and many people that talk against subluxations don't know the history and the philosophy of chiropractic and don't understand what the chiropractic subluxation means, and it's not that old fashioned concept that consider vertebra out of place. And then, who says subluxation do not exist? Thank you.